Okay. Several years ago, I had the opportunity to do a sabbatical in Bern, Switzerland, and I spent 6 months in Bern. And sometimes during the weekends, I had the opportunity to walk around in the old city of Bern, Switzerland. And as in many medieval cities, you have these beautiful old statues. And one statue just intrigued me tremendously. And this is a statue of an ogre eating a baby. And this ogre's name in Swiss German is the Kindlifresser, the child eater. And I was always wondering what the child eater, what this signified. And I talked to some people from Switzerland, from Bern, about this, and they said, well, maybe in the old times, parents would take their children and show them this Kindlifresser, and if they got naughty, then they would scare them. Well, I don't know if that's the case, but I think I've come up with a different explanation. And that explanation is that the Kindlifresser is a neonatologist. So why do I say that? Well, neonatologists sometimes are afraid to nourish babies. And sometimes the enteral nutrition is not provided for these babies for a period of time. Same thing with parenteral nutrition. And this is at a time that these babies really need their nutrition tremendously because they have these high nutritional needs that Professor Hay was talking about. Here again, I'm going to show you this work that was done by Dr. Eckhard Ziegler looking at babies at different gestational ages, and here are their weights, percentage water, percentage protein, and again you can see the lipid stores in some of these very small babies are extremely low. And if you don't nourish some of these babies immediately after birth, they will starve to death. Within 24 hours, they will begin showing signs of starvation. What about enteral feeding? Well, we are very concerned about feeding babies by the enteral route. Neonatologists are scared of this disease, necrotizing enterocolitis. We also see some babies with feeding intolerance. And because of this, we sometimes do not feed babies shortly after birth and are very reluctant to advance feedings. And we will be talking about this as we go on. So we use all kinds of excuses not to feed these babies, and these excuses include low APGAR scores, umbilical artery catheters, apnea and bradycardia, babies are in mechanical ventilation, CPAP, they're getting vasoactive drugs such as dopamine or indomethacin. None of these have been shown to be a valid excuse, a valid reason by studies not to provide enteral nutrition to babies. We also have this last factor, that TPN is available, that we can actually get babies to grow very nicely by using TPN. But there are many problems associated with TPN, and we will talk about these as we go along. So what about the growth of the intestine? And that's what I want to talk about over the next half an hour or so, is the growth of the intestine and the capabilities of the developing intestine. I want to talk about not only the anatomy, but also some of the functional aspects, such as swallowing, GE sphincter function, gastric emptying, intestinal motility, and then digestion, absorption, and assimilation. The human fetal intestine elongates around 1,000-fold from 5 to 40 weeks. The length doubles in the last 15 weeks of gestation, so that the mean length at birth is around 275 centimeters. If you look at the intestinal surface, you find these villi. On top of the villi, you will find microvilli. And this increases the surface area of the intestine tremendously, so that in the adult, the surface area of the intestine is approximately the size of a tennis court. There are certain physiologic processes that the fetus undergoes. In the last trimester of pregnancy, the fetus swallows approximately 450 milliliters per day of amniotic fluid. This amniotic fluid does contain some nutrients. There's approximately 0.5 grams of protein that these babies get every day through the amniotic fluid into their gastrointestinal tract. They also get some lipids from the sloughed off epithelial cells. So there are some nutrients that are being supplied to the fetal gastrointestinal tract during this period of time. This is sometimes suddenly interrupted at the time of preterm birth because neonatologists are reluctant to feed babies. We do have some problems in these babies. We have mechanical difficulties. There's suck, swallow, and coordination. And this necessitates tube feeding. Usually babies less than about 32 weeks gestation cannot coordinate their suck and swallow responses, and so therefore we have to put a tube into their gastrointestinal tract. The esophageal sphincter appears to be more disorganized in the very preterm infant. There are more transient lower esophageal relaxations in the preterms. So that allows for more gastroesophageal reflux to occur. Gastric emptying is also delayed in these preterm babies. The motility is disorganized so that you do not have migrating motor complexes. You have a much more chaotic form of intestinal motility. So that with all these factors, the gastroanal transit in extremely low birth weight infants is about 2 to 5 days, and that compares to term infants where they have approximately 12 to 24-hour gastroanal transit, much faster in the term infant. What about gastroesophageal reflux? Well, there's a term called GER, which is gastroesophageal reflux, and gastroesophageal reflux disease, GERD. These are related but different processes. The gastroesophageal reflux is a physiologic event which just allows for retrograde movement of gastric contents into the esophagus. You have to have some capability for gastroesophageal reflux to occur so you can have equilibration between the gastric contents and the esophagus. But this can turn into disease, which is a pathologic entity that includes complications derived from gastroesophageal reflux. Some of these complications include a failure of the baby to grow, esophagitis. Sometimes you have so much reflux that it actually causes aspiration into the lungs. Do we have clinical signs in babies that are reliable for the diagnosis of gastroesophageal reflux disease? Well, let me ask you, can you tell if a baby is having gastroesophageal reflux just by looking at the baby? Sometimes, okay, sometimes, okay, good, good. I can tell you that when I make rounds in the neonatal ICU, I hear just about every day from the nursing staff, this baby is having gastroesophageal reflux. This baby is having gastroesophageal reflux. Well, there's some studies that have actually been done looking at this, how reliable we are as clinicians to be able to tell if there is gastroesophageal reflux or not. This was a study that was done by Snell in the year 2000, reported in Journal of Pediatric Gastroenterology and Nutrition. And what they did in this study was something fairly clever. They filmed babies for prolonged periods of time and also had a tube in their esophagus looking at acid reflux. Then they had observers look at these films. Physicians and nurses look at the films. And they recorded 20 episodes of acid gastroesophageal reflux by the tube that was in the esophagus. And then they had the observers record when they thought gastroesophageal reflux was taking place. And they had a 74% observer agreement in episodes of coughing, hiccuping, gagging, head retraction, etc. Those are considered to be signs of gastroesophageal reflux. So the people all agreed, 74% agreement of when there was gastroesophageal reflux. But there was no behavioral pattern that was temporally associated with the gastroesophageal reflux, with the acid reflux. In other words, the observers were not able to really tell if acid reflux was taking place or not. Sometimes you hear about apnea and bradycardia being caused by reflux. Well, there is a strong association, at least physiologic evidence, that stimulation of laryngeal afferents elicit central apnea and laryngeal adduction. In other words, if you stimulate the laryngeal afferents by water or other liquids, you may actually get this reflex response. However, studies have shown, here's just a few of these studies, shown that gastroesophageal reflux and apnea do not appear temporally related in preterm infants. Actually, apnea precedes reflux more often than reflux precedes apnea. Very interesting study that's recently been done looking at some of the medications that are given to treat apnea and reflux, at least what we think is apnea related to reflux. This is a study where in preterm infants with bradycardia, which was attributed to gastroesophageal reflux disease, it was found that preterm infants had more bradycardia when receiving the reflux medications, the metoclopramide and the ranitidine. They had more bradycardia when receiving these medications than when receiving the placebo. And the reason for this was thought to be that histamine receptors are present in the heart, and ranitidine is known to cause bradyarrhythmias. Work has been done to look at positioning of babies with gastroesophageal reflux. This is work that was done in Italy by Coviglia and colleagues in 2007. The left side down position showed the lowest esophageal acid exposure, 0.8%, in the early postprandial period, that's right after feedings, and the prone position showed the lowest esophageal acid exposure, 5.1%, in the late postprandial period. So the conclusion here is that placing premature babies in the prone or left lateral position in the postprandial period is a simple intervention to limit GER. So you can go about this by, in the early postprandial period, placing the baby on the left side down position, and later on, before the feedings, placing the baby in the prone position. What about using acid blocker therapy? Many years ago, prior to about 7 or 8 years ago, it was very common practice, at least in the United States, to use H2 blockers in preterm babies. At that time, we were actually using a lot more steroids than we are using now. And it was thought that those babies who were getting steroids had a higher propensity for gastric bleeding, more stress. And so a lot of these babies were placed on H2 blockers. In fact, it got to the point where all babies in some units were being placed on H2 blockers. Studies have been done to look at this more closely, and this is work that was done by Ronnie Gillette and colleagues from the University of Rochester, looking at data from the National Institutes of Health neonatal network, where they found that H2 blocker therapy was actually associated with a greater likelihood of development of necrotizing enterocolitis. This is very interesting from the fact that another study was done in 1990 at the University of Buffalo by Carrion and colleagues. And what they did in this study was they actually took two groups. In one group, they acidified a formula. They placed a little bit of hydrochloric acid into one of the formulas and had a control formula and found that the acidified formula actually resulted in less necrotizing enterocolitis. So that suggests that acid in the stomach is actually a good thing, and you don't want to get rid of that acid in the stomach. Now, what about feeding tolerance? There are some things that we can do for babies to try to improve feeding tolerance. There are some non-pharmacologic methods that can be used. Dr. Carolyn Berseth has done some studies looking at prolonged enteral feedings versus bolus feedings. Now, I'm not talking about continuous, but giving a feed over 1 hour or over 2 hours instead of over just a 10 or 20-minute bolus. And those feedings, those studies have shown a greater gastric emptying response by prolonging the enteral feeding to 1 hour or 2 hours. So there are some tricks like that that can be done to improve gastric emptying and feeding tolerance. But if some of those non-pharmacologic methods fail, it's been suggested that erythromycin be used. And this is a very nice review from my colleague, Dr. P.C. Ung from Hong Kong. And P.C. did a review of 10 randomized controlled studies in preterm infants. And he found that when used for rescue, erythromycin was associated with a shorter time to attain full enteral feeding. That high-dose erythromycin, 12.5 milligrams per kilogram given Q6 hours orally, reduced the incidence of parenteral nutrition-acquired cholestasis by almost 50%. And it was thought that this third factor may have been due to the fact that these babies had better feeding tolerance with the use of erythromycin. So it was concluded that the current information favors the use of rescue rather than prophylactic treatment immediately, favored that the rescue rather than prophylactic treatment, intermediate to high-dose erythromycin rather than low-dose erythromycin, and administering this medication intragastrically rather than intravenously. And then a caveat was given that oral erythromycin should be used cautiously and selectively in preterm infants with moderately severe functional GI dysmotility and in whom a structural obstructive lesion has been excluded. Okay, so what does this mean? You have a preterm baby who you are trying to feed enterally, and you're trying to advance the feedings. And you have done some positional things. You've altered the type of feeding that the baby is getting. You have increased the amount of time that you are giving the infusion, and it doesn't work. So then you try the erythromycin. And the way it is recommended to try the erythromycin is to do a trial of the intermediate to high-dose oral erythromycin for 2 days. And if you do not get improved feeding tolerance after 2 days, you stop the erythromycin. If you do get a positive response, you keep the baby on the erythromycin for approximately 2 weeks. You take the baby off after 2 weeks, and you see how the baby does after 2 weeks. There are some complications associated with erythromycin usage. Pyloric stenosis has been one complication associated with erythromycin usage. Not in these studies, but other studies. Also, what the erythromycin does to the intestinal microbial ecology, we don't know. But I think at this time, if we use erythromycin very carefully, as I mentioned, it's probably safe. What about the intestinal motor function in preterm infants? As I said before, there's an absence of migrating motor complexes. There's a predominance of clusters and an absence of mature motor response to feeding. So if you look at a mature gastrointestinal tract, if this is the top of the gastrointestinal tract, this is the bottom, you have migrating motor complexes that propulse food down the gastrointestinal tract. In the preterm infant, you have this chaotic activity that does not propulse food in a very normal way down the gastrointestinal tract. So a lot of these babies have delayed passage of meconium. It's delayed in about 20% of infants with birth weights less than 1,500 grams. And in some of the babies who are not being enterally fed, you may not see meconium passage for up to 10 days in babies less than 1,250 grams. You don't put anything into the gastrointestinal tract, you don't get anything out. It has been suggested to use routine enemas or to use routine glycerin suppositories in these babies. The evidence for that is still lacking in terms of helping these babies prevent necrotizing enterocolitis or actually improve feeding tolerance. Okay, so the next area I'd like to talk about is digestion, absorption, and assimilation. Those are actually three different physiologic processes. Digestion occurs in the lumen of the gastrointestinal tract. Absorption occurs at the enterocyte interface at the microvillus membrane. And assimilation occurs in the enterocyte and beyond. As mentioned by Dr. Hay, the accretion rates of the reference fetus in utero is estimated to be about 3.5 to 4 grams per kilo per day in early third trimester. If these babies are born early, and if you attempted to feed them only by the gastrointestinal route with mature human milk, you would require around 330 milliliters per kilo per day of this milk to meet this requirement. That's a lot of human milk to try to give these preterm babies, and most of these babies would not tolerate that. So these babies need alternative ways to go about this. But we will be talking about parenteral nutrition, but right now I want to talk about these digestive and absorptive processes. What is the capability of the preterm infant to digest and absorb and assimilate? Well, in the upper gastrointestinal tract, one of the first mechanisms that we have is hydrochloric acid production. Hydrochloric acid works with pepsin and other enzymes in the upper gastrointestinal tract to digest proteins from large protein structures into smaller oligopeptides. Here we have what happens in the postnatal period in infants at around 32 to 33 weeks gestation, and this is acid output. This is the basal state, this is pentagastrin stimulation. And here we see for the first 2 to 3 weeks, we have limited gastric acid output. These preterm babies just do not make very much gastric acid. When you go further down into the gastrointestinal tract, you have the production of pancreatic enzymes. These pancreatic enzymes further break down these proteins into oligopeptides. One of the first stimuli to the pancreas to produce some of these proteases is an enzyme called enterokinase, which comes from the upper gastrointestinal tract in response to food. In very preterm babies, we have a limited amount of enterokinase which is available to these babies. So because of that limited amount of enterokinase, you have limited protein digestion. So just to summarize this, the enterokinase is produced in the upper intestine in response to food. This is an activator of other enzymes which are important in protein digestion via the proteases, but this enterokinase has been found to be extremely low. This is work that was done in the 1970s at Boston Children's Hospital, where Dr. Martin, Harvard University, where Dr. Martin is from, but a long time ago, 1977, this work was done showing that there's very low enterokinase production in the preterm baby. Okay, so digestion of proteins seems to be somewhat limited in these babies. What about protein absorption? So after the luminal hydrolysis, after these proteins in milk are broken down into oligopeptides, these peptides are further hydrolyzed at the microvillus membrane. Some amino acids and oligopeptides are absorbed via transporters. Some of these peptides are absorbed intact, while others have to be further hydrolyzed by intracellular enzymes. It's very interesting that di- and tripeptides are actually taken into the gastrointestinal tract better than single amino acids. The transport processes for di- and tripeptides, these small oligopeptides, is actually better than single amino acids, something important to remember when you use highly hydrolyzed formulas or single amino acid formulas. So what about the absorption? It's partially and temporarily poor because of low gastric acid and upper GI enzymes. And the question that we ask is, if we provide hydrolysates for these babies, would that be a better way to go about feeding them than giving whole protein formulations? Well, one study that was done by Dr. Walter Mihatch in Germany, I think was very interesting in this regard. He gave a hydrolyzed protein formula versus standard preterm infant formula in babies weighing less than 1,500 grams. The time from initiation of enteral feeds to full feeds was shortened with the hydrolyzed protein feeding, 10 versus 12 days, so by about 2 days. But he did not have a human milk control in that study. And if you compare his feeding tolerance of these formulas to human milk, the human milk still had much better tolerance, at least from other studies, than his group. Does this 1 to 2 days matter? Well, possibly it does if you put it all together. You want to have babies going home sooner. You want to be able to have them initiate their full feedings more readily. However, you have to be very careful with this. At least in the United States, we still do not have a protein hydrolysate formula that is specifically meant, that is nutritionally adequate for preterm babies. And so you have to look very carefully at the kind of formula that you want to feed these babies. If you have to feed these babies with a formula, you have to be very careful if you want to feed a protein hydrolysate formula to preterms, because it has to have the adequate nutrition, calcium, phosphorus, protein, etc., for the preterm infant. What about lipids? About 70 to 80% of lipids that we eat and lipids that we feed to our babies is in the form of triglycerides. So what is a triglyceride? You have a glycerol backbone, and you have fatty acids, 3 fatty acids, attached to this glycerol backbone by these ester bonds. We have enzymes called lipases which act on these. The primary activity of lipases is at the 1 and at the 3 position, so that if you have lipase activity, you have these triglycerides turning into 2 fatty acids and 1 monoglyceride. You have lipases of several different origins. In fact, there's one lipase that is found in human milk that is obviously not found in formulas. There are too many processes that formulas have to undergo to have lipases active in the formula. This is called bile salt stimulated lipase. And the way this acts is that it is not active until the lipase from the human milk reaches the the upper gastrointestinal tract, and bile salts come into contact with that lipase. This bile salt stimulated lipase, again, is higher in milk of mothers delivering preterm than in mothers delivering at term. We have several other lipases. There's one lipase which is produced at the back of the tongue called lingual lipase. It was thought to, at one point, be important for preterm babies. But if you think about most of our preterm babies who have tubes in their stomach, they probably just bypass that lingual lipase. And so for the most part, the lingual lipase is probably not that important in fat digestion in preterm babies. But we do have other lipases that are produced by the pancreas, and these pancreatic lipases take some time to develop. Usually they are not present in very high quantities in the very low birth weight baby. We also have bile acids in our preterm babies that are thought to be important. The way these bile acids work is that they act as detergents, and they emulsify fats. If last night I went to dinner, and if I had a meal that was very fatty and I got some fat on my thigh, okay, and if I wanted to get that grease spot out of my thigh, would I just put water on it? No, it would not get rid of it. I would take some water and put some detergent into that water, and that would then get rid of that grease spot. Okay? Well, the same thing happens in the gastrointestinal tract. These bile acids act as emulsifying agents. They're amphipathic, and they take big lipid molecules and break them down into smaller lipid molecules so that you have a greater potential for fat mucosal interaction. This is important for the long-chain fatty acids, those of C18, 18 carbons or greater. They're not important for the short or medium-chain fatty acids. Where are the bile acids produced, and do we have enough of these bile acids in preterm babies? They're produced in the liver. That's where they're synthesized. Then they go into the gastrointestinal tract, and then they are reabsorbed. Well, the production is lower in the liver, and the reabsorption of the fatty acids, of these bile acids, is also lower in the ileum. So what happens is that you have this concentration of bile acids in the upper gastrointestinal tract of preterm babies, which is generally less than 2 millimolar, usually around 1 millimolar, and critical micellar concentration, where you actually have a lot of micelle formation occurring, is around 2 to 3 millimolar. So oftentimes these preterm babies have less than critical micellar concentration of bile acids, and so for certain long-chain fatty acids, their bile acid secretion and reabsorption is just not adequate to have the greatest function of lipid absorption. Now, we also have what happens in this transport or delivery phase. Here we have in the intestinal epithelial cell, you have a reformation of the free fatty acids and the two monoglycerides. They attain a protein coat, and with that protein coat, they're called chylomicrons and lipoproteins, and they go into the lymphatic system. This is what happens for the long-chain fatty acids. This process does not have to occur for the medium-chain fatty acids or short-chain fatty acids. The short-chain and medium-chain fatty acids go directly into the portal vein to the liver, and it's a much simpler process. And this is one of the reasons why for certain babies and for certain individuals who have obstruction of their lymphatics, of their lacteals, we have to use more medium-chain triglycerides because it's a much simpler process of digestion and absorption and assimilation. So for the low birth weight infant, here's a quick summary. Digestion of lipid is temporarily poor. especially for long-chain lipids because of low bile acid secretion and reabsorption? Could this be addressed by the use of medium-chain lipids? Well, we do use a lot of medium-chain lipids in our formulas for preterm babies. What is the evidence that they're actually helpful? Well, certain single trials have suggested that they might be helpful, but when you put all these trials together in a Cochrane database, there's no evidence for differences in short-term growth. There's conflicting data as to formula tolerance, and no difference in morbidity, such as necrotizing enterocolitis. So for the most part, it doesn't seem to make sense to use these medium-chain triglycerides from this study perspective, but from a physiologic perspective, it still makes some sense. What about lactose and lactose intolerance in preterm babies? The myth that we have is that preterm babies are not able to absorb lactose. But what's the major carbohydrate in human milk? Lactose, okay? There's no sucrose, no maltose in human milk. Lactose is the major carbohydrate. So where does this all come from? Well, again, going back to some of these studies that were done in the mid to late 1970s, these studies were done in a very interesting way. They were able to take small pieces of intestine from fetuses who aborted or were miscarried, and also took some samples of biopsies from babies, various gestational and postnatal ages. And they looked at duodenal, jejunal, and ileal lactase activities and other disaccharidase activities. And here they found that at 22 to 24 weeks gestation, 26 to 29, as you increased in age, you had more lactase activity. So it was thought that the earlier a preterm baby was born, the more likely that preterm baby was to be lactose intolerant. So this actually led to some of the formula companies adding corn syrup solids, tapioca starches, and other hydrolyzed starches, for example, polykose, to their formulas and taking the lactose out. Is this potentially a problem? Study that was done at Baylor University by Drs. Chandler and Schulman in the late 1990s addressed this. They had 135 preterm babies, 26 to 30 weeks gestation, and they measured the lactase activity using a very indirect approach, a lactulose to lactose ratio in the urine. I don't have the time to go through that with you, but that's the technique that they used. They found that early feeding resulted in greater lactase activity at 10 days of age by 100%, and that human milk feeding resulted in higher lactase activities than formula feeding. What happens to some of the undigested lactose in the gastrointestinal tract of these babies? Well, if you don't have a lot of lactase activity, you have to do something with that unhydrolyzed lactose. Well, one thing that can happen is that the bacteria in the gastrointestinal tract can break down that unhydrolyzed lactose into short-chain fatty acids, 2, 3, and 4 carbon-containing short-chain fatty acids, acetate, propionate, and butyrate. And here we see dietary lactose going through the gastrointestinal tract, some of it being absorbed, but some of it not being absorbed, the bacteria acting on this, and you have these, the acetate, lactate, propionate, and butyrate actually being taken in to the colon. Butyrate is actually one of the major fuels for the colonic epithelial cell. Glutamine and glucose are major fuels for the small intestine, but butyrate is a major fuel for the colonocyte. Butyrate is also very important for maintenance of intestinal epithelial tight junctions. And so we can actually think of lactose in some way being a prebiotic, where we actually stimulate the growth and utilize these fermentative processes in the gastrointestinal tract to promote some of the physiologic processes. Butyrate, again, I want to say is very important. It increases proliferation. It increases apoptosis and differentiation, tightens junctions. But higher doses are thought to be toxic. One study that looked at intestinal epithelial cells found that up to 4 millimolar actually was helpful, but 8 millimolar killed the cells. So could this be used as a postbiotic or a prebiotic instead of a probiotic? And here's just one interesting study that was done in New York looking at intestinal epithelial cells and looking at something called transepithelial resistance. This is where you take a monolayer of intestinal epithelial cells and grow them in culture, and you have probes at the top and at the bottom of these cells, and you stimulate an electrical current, and the greater the transepithelial resistance, the tighter are the junctions between the cells. And here we see that with butyrate, you see an increase in transepithelial resistance or tighter junctions between the cells. And we also see some of these proteins that are involved in tightness of junctions between epithelial cells actually going higher with the use of butyrate. So this is one of the reasons why using lactose may actually be a very positive thing in these babies. Okay, so I've talked about some of the digestive, absorptive, and assimilative processes in the gastrointestinal tract. We'll talk about more practical strategies in a later lecture. And I'd like to end here that the GI tract of the premature infant has several immaturities related to anatomy and function that do not allow for immediate introduction of full enteral feedings, and we can incorporate strategies to safely nourish these babies. We'll talk about those later. Questions? I also want to say that we will have time for discussion later, so if you have questions that you don't want to ask right now, or if you feel that you want to wait, please write down questions, and we can actually take those at the end of the day. Okay? Yeah.
Thank you for the excellent conference. In Greece, at this point, erythromycin is not available, and our gastroenterologists say that the other types, like clarithromycin or azithromycin, are not helpful in increasing the gastric motility. Is that true? And what else can we do? Because we have babies that develop cholestasis.
Yeah, to my knowledge, those have not been studied, certainly not as extensively as erythromycin. Cami, Ed, does anybody know of any studies with clarithromycin? I'm not aware of those studies. So, again, I think erythromycin is probably the best way to go. I don't know if those other drugs may be helpful or not. Probably best not to, without the evidence. Yes.
Sir, you mentioned before that using the H2 receptor blockers might increase the chance for necrotizing enterocolitis. This also goes for the full terms baby? What has to do with the gestational age?
Well, the full-term baby has a much lower likelihood of development of necrotizing enterocolitis. And the mechanisms and we'll talk about this, the mechanisms of development of necrotizing enterocolitis in the term baby are probably very different than the mechanisms that we see in the preterm. And so I don't know if that would actually alter necrotizing enterocolitis in the term baby, but there are studies that have been done in adult intensive care units looking at the use of H2 blockers, and it's been found that the routine use of H2 blockers in an older population actually results in more sepsis, not necrotizing enterocolitis in the adult, but more sepsis.
Good morning, Baldassarre from Bari. Generally, we have a lot of problem with refeeding post-surgical newborns. Is it possible to use erythromycin also in these newborns, for example, after duodenal atresia and so on? Because generally in these newborns, central feeding, it's need a long time.
Yeah, I think that you have to be very careful with that because in some of these cases, the gut is not really ready, and it may be showing you that it is not ready because of the pathology that was there before, not because of physiologic immaturity. So that's a different situation. In some situations, it might be worth a try, but I'd be very, very careful in those kind of situations.
And the dose, the right dose is about 5 milligram per gram.
I would refer you to Dr. Ng's review article in Neonatology. He talks about the dosage scheduling, and he talks about the intermediate to the high dose being 12.5 milligrams per kilo given 4 times a day,
okay,
6 hours. Yeah.
Thank you.
Thank you very much. I would like to ask you if in the cases the babies need TPN, do you recommend the minimal oral feeding, just a few drops, a small amount just for enteral stimulation? I think it's very important. And one more question. I have the feeling that we overdiagnose gastroesophageal reflux, the normal gastroesophageal reflux in every newborn. And I have the feeling that we overtreat newborns, even prematures, giving ranitidine, sometimes prokinetic, which sometimes is forgotten for many months. And we forget the danger of heart side effects and increasing the gastric pH, which is rather high. And one more question. In the case you suspect gastroesophageal reflux in a preterm, which is very difficult to prove if you don't combine with impedance, because pH monitoring relies only on acid reflux. Do you recommend doing pH monitoring?
Okay, so you have 3 major points that you raised. And point number 1 was minimal enteral feedings, and I totally agree. And we'll be talking more about minimal enteral feedings and some strategies for minimal enteral feedings and guidelines to use for minimal enteral nutrition. Minimal enteral nutrition is something that you use to stimulate the gastrointestinal tract. You don't use it for nutrition of the entire baby, but it's something that you provide to the baby to more as a pharmacologic food to prevent atrophy of the gastrointestinal tract and to stimulate motility and other physiologic aspects. So yes, minimal enteral nutrition, a very important point. Your second point had to do with the overuse of some of these drugs. And yeah, I totally agree with you. I think that many units overuse these, and we should really be asking, why are you using the ranitidine, the H2 blockers in these babies? They do have their side effects. I do know that prior to about 7 or 8 years ago, we were also using this drug called cisapride, Propulsid, very, very commonly. And why were we using it? We were using it not to improve feeding tolerance in babies. We were using it to prevent apnea and bradycardia. And there were no studies done to look at this drug to prevent apnea and bradycardia. And then, as you say, there are some side effects, and that particular drug started to show side effects. Studies emerged showing that there were torsade de pointe, some real problems, cardiac problems with that drug. And so the Food and Drug Administration in the United States and some other places said, no, you cannot give this drug anymore to these, to these babies. So we are not using it. Then your third point had to do with the monitoring of gastroesophageal reflux. And I think that to look for acid reflux, you have to do pH monitoring. But you can actually use other technologies to look at reflux. Just impedance is one way to look at reflux that is not acid. Most places do not have impedance available. We do not have impedance available in our hospital. Okay, so I think that for the most part, we are left with, in most of these babies, treating them by our, examination. But again, as I mentioned and as you mentioned, the physical exam in most of these babies for gastroesophageal reflux is very poor. And so most of these babies really do not need, the routine preterm baby does not need gastroesophageal reflux medications. The kind of baby that I would give routine gastroesophageal reflux medication to would be a baby with tracheoesophageal fistula postoperative, congenital diaphragmatic hernia postoperative. Okay, those would be some examples.